Welcome. In this session, we are going to talk about secondary and metastatic tumors to the orbit. And orbital secondaries arise from lesions arising primarily in adjacent contiguous structures such as the globe, eyelids, sinus, lacrimal drainage system, and brain. Starting with sinus disease, which may involve the orbit, we have mucocele, silent sinus syndrome, and malignant tumors of the sinus. Mucocele are benign cystic structures filled with mucus and/or pus and are lined by pseudostratified ciliated columnar epithelium with goblet cells, reminiscent of respiratory epithelium, and they develop from accumulation of mucus and/or pus following obstruction of sinus drainage. Mucoceles involving the orbit usually arises from the frontal or ethmoidal sinus and presents as a slowly growing mass, entering the orbit either by expansion when it will be lined by a thin layer of bone, or erosion when there will be dehiscence of the orbital wall separating the orbit from the involved sinus. Mucoceles can also enter the intracranial space. A patient with an orbital mucocele will present with features of sinusitis including headache, and there will be displacement of the globe either laterally from an ethmoidal mucocele or inferiorly from a frontal mucocele. A fluctuant mass can be palpated in the superior or medial orbit. On imaging, opacification of the involved frontal or ethmoidal sinus can be seen. So here we see opacification of the ethmoidal sinus, and the bone separating the orbit from the involved sinus can be dehiscent or may be present just as a lining of thin cortical bone. The cyst contents appear heterogeneous on imaging and do not enhance with contrast agents. Treatment of mucocele requires drainage of the cyst, removal of the cyst wall, along with either improving drainage of the involved sinus or obliterating the involved sinus with bone or fat. Silent sinus syndrome occurs from subclinical maxillary sinusitis, which can cause erosion of floor of the orbit, and erosion of the floor of the orbit results in enophthalmos because of inferior and posterior sinking of the globe, and this enophthalmos may be accompanied by upper lid ptosis, a deep superior sulcus above the upper lid, and diplopia. The enophthalmos in silent sinus syndrome can often be sudden in onset during changes in environmental pressure, such as during air travel, and treatment involves repair of the orbital floor and improving the maxillary sinus aeration. Malignant tumors of sinus involving the orbit include squamous cell carcinoma or adenocarcinoma, and they usually arise from the maxillary sinus. So malignant tumors of sinus involving the orbit usually arise from maxillary sinus, and mucoceles involving the orbit usually arise from the frontal or the ethmoidal sinus. And malignant tumors of sinus usually present with nasal obstruction, epistaxis, and epiphora. And orbital involvement from malignant tumor of sinus requires exenteration followed by radiotherapy. Fibrous dysplasia, osteomas, and sarcomas arising in nose, paranasal sinus, and facial bones may also spread and secondarily involve the orbit. Basal cell carcinoma arising in the skin is the most common secondary orbital malignancy, and basal cell carcinomas involving the orbit can arise from the eyelid or from the eyebrow. Basal cell carcinomas in the medial canthal area are more prone to invade the orbit because of discontinuities in the orbital septal system in the medial canthal region, and orbital metastasis from basal cell carcinoma can present with proptosis, ptosis, diplopia, and pain. On imaging, we will find an irregular shaped well-defined mass lesion extending posteriorly through the orbital septum. The lesion can have cystic spaces and shows moderate contrast enhancement on CT scan. On MRI scan, the lesion appears to be homogeneous, iso-intense in T1 and slightly hyper-intense in T2, but shows marked enhancement with gadolinium contrast. Basal cell carcinoma limited to the anterior orbit can be excised, but basal cell carcinomas extending to the posterior orbit require exenteration. With treatment, orbital metastasis from basal cell carcinoma have a good prognosis for life, but late recurrences can occur even after treatment. Orbital melanoma commonly arises from secondary spread from choroid or the conjunctiva. Primary orbital melanoma are extremely rare but can arise from a nevus, or in patients with oculodermal melanocytosis. Orbital melanoma may also occur as a metastasis from a distant primary melanoma. So melanoma of the orbit is most commonly secondary and only occasionally primary or metastatic. Clinical features of a patient with melanoma in the orbit include proptosis, ptosis, chemosis, diplopia and pain. And in case of recurrence of melanoma in the orbit following enucleation for a primary ocular melanoma, forward displacement of the orbital implant can occur. On imaging, melanoma of the orbit appears as a homogeneous, irregular, infiltrative mass lesion, and orbital melanomas arising from the choroid of the adjacent globe are intraconal, and they show continuity with the choroidal mass lesion, and the choroidal mass lesion has a similar appearance on imaging with a collar button or dome shape. The tumor appears hyperintense on both T1 and T2 MRI with diffuse enhancement with gadolinium contrast. On biopsy, a secondary orbital melanoma in contiguity with an existing choroidal mass is usually pigmented, but post-enucleation recurrences are usually amelanotic, and melanomas are positive for S100 and HMB45. Most orbital melanomas require exenteration, and prognosis is poor with a high mortality rate. Metastatic tumors to the orbit occur from a distant primary site and constitute 2 to 3% of all orbital tumors, and approximately 50% of orbital metastases present without previous diagnosis of the primary malignant tumor. In children, orbital metastasis is more common than uveal metastasis from a distant primary, and orbital metastasis in children usually occur from neuroblastoma, leukemia, Ewing sarcoma, and nephroblastoma. In adults, uveal metastasis is more common than orbital metastasis, and orbital metastasis in adults usually arises from primaries in lung, breast, and prostate. And orbital metastasis may be the first sign of cancer in 25% of patients with orbital metastasis. Clinical features of orbital metastasis include pain with signs of inflammation such as lid swelling and chemosis. There can be bone destruction, especially the lateral wall, and early onset of ophthalmoplegia. Extraocular muscles and the lateral wall of the orbit or the greater wing of the sphenoid being vascular is commonly involved. Neuroblastoma is the most common orbital metastasis in children with a mean age of presentation of 2 years, and it is the second most common orbital malignancy of childhood after rhabdomyosarcoma. And the primary tumor usually occurs in the adrenal medulla or the sympathetic chain in the retroperitoneum, mediastinum, or in the neck region. Neuroblastomas are considered to be peripheral nervous system counterpart of retinoblastoma. 10 to 20% of neuroblastomas metastasize to the orbit, and orbital metastasis can occur late in the disease course, as we will be seeing. Less than 10% of patients with neuroblastoma present with the orbital metastasis. Primary orbital neuroblastoma can occur from ciliary ganglion, but is very rare. Metastatic orbital neuroblastoma presents characteristically with a sudden onset of rapidly progressing proptosis with lid ecchymosis, and 40% of the patients have a bilateral presentation. Please look up on the net for an image of neuroblastoma because I could not find a non-copyrighted image. So in a young child with sudden onset of rapidly progressing proptosis with lid ecchymosis, neuroblastoma should be in the differential diagnosis, and the lid ecchymosis can lead us to mistake the neuroblastoma for trauma. Ocular signs due to the primary tumor itself for which the orbital metastasis is not required include Horner syndrome and opsoclonus, which we have discussed in the section on neuro-ophthalmology. And Horner syndrome can occur with ipsilateral cervical neuroblastoma involving the cervical sympathetic chain. Neuroblastoma patients with opsoclonus have a good prognosis for survival. Patients with orbital neuroblastoma also have systemic signs arising from the primary tumor, and these include abdominal swelling, edema from venous obstruction, renal hypertension, and presence of catecholamines in the urine. On imaging, we find an irregular, poorly defined mass with bone destruction and separation of sutures in the lateral orbital wall. So this is a CT scan showing lateral orbital wall destruction in a patient with neuroblastoma. And in this patient, there is involvement of the contralateral orbit also. Intracranial metastasis can also be seen in neuroblastoma, and on biopsy the tumor appears bluish. And on histopathological section, we will find small round cells with calcification and necrosis. Electron microscopy characteristically shows neurosecretory tubules. Treatment of orbital neuroblastoma is primarily chemotherapy, but adjuvant radiotherapy is indicated in cases with compressive optic neuropathy. And when the primary tumor is diagnosed before 1 year of age, the 5-year survival rate is 85%, as compared to 36% 5-year survival rate when the primary tumor is diagnosed beyond 1 year of age. And since orbital metastasis usually occurs at or above 2 years of age, it is associated with poor prognosis. Orbital involvement in leukemia can occur unilaterally or bilaterally, and the most common variant of leukemia to involve the orbit is acute lymphoblastic leukemia. A patient with orbital leukemia at presentation typically does not have signs of systemic disease, which inevitably follows in a few months' time. Rarely, myelogenous leukemia can occur primarily in the orbit, and they are termed as granulocytic sarcoma or chloroma, the name deriving from the greenish discoloration of the tumor due to myeloperoxidase enzyme. Orbital leukemia can present with unilateral or bilateral proptosis along with inflammatory signs such as lid swelling and chemosis, which can lead us to mistake orbital leukemia for orbital cellulitis. Ecchymosis of overlying skin can be present, and rarely there can be sudden onset of visual loss with or without optic nerve head swelling from involvement of the optic nerve. And this is a medical emergency requiring urgent management with orbital radiotherapy to rescue vision. Imaging usually shows bilateral orbital involvement but without bone destruction. So here we see involvement of the left orbit, but there is no bone destruction and the orbital wall is intact. In female patients with orbital metastasis, breast carcinoma is the most common primary site. An orbital metastasis in breast carcinoma can occur many years after excision of the primary tumor. Breast carcinoma can have a fibrous response resulting in enophthalmos and movement restriction of the globe. A similar fibrous response is also found in orbital metastasis from gastric carcinoma. Orbital metastasis from breast tumor can respond to hormone therapy if the tumor is hormone receptor positive, and hormone receptor positivity status of the orbital metastasis can be different from the hormone receptor status of the primary. In male patients with orbital metastasis, bronchogenic carcinoma is the most common primary. The primary lung lesion can actually be very small in size. Orbital metastasis from prostatic carcinoma usually occurs in elderly males and can present with signs of acute inflammation. Pain is common in this situation, and imaging can show an osteoblastic or bone-forming lesion in the orbit. On imaging, metastasis from solid tumors appear as poorly defined infiltrative masses, and most orbital metastasis from solid tumors are managed with palliative radiotherapy and chemotherapy. However, metastasis from tumors with a better prognosis, such as renal cell carcinoma and carcinoid tumors, are often treated with wide surgical excision. Thank you for listening.